All right, here's chapter 29, trauma to the head, neck, and spine. This is an interesting chapter because we see quite a few of these injuries on a regular basis, especially the head injuries that we'll get into. So a quick review of the nervous system. We know obviously the central nervous system is made up of the brain and spinal cord, and then we also have our peripheral nervous system that involves all of our sensory nerves that branch out to other parts of the body. Um, our ability to assess the peripheral nervous system gives us a lot of information on what's going on with the central nervous system. So obviously, if we have a lack of sensation in the right hand, we want to know, okay, is that because some type of nerve is being pinched? Let's say that we dislocate our shoulder and we're pinching the nerves going into the arm, and as a result, we have lack of sensation. Okay, that explains it. But if that's not the case, if let's say we just have generalized weakness of the right arm, and there's no specific trauma to support that, then are we looking at some type of stroke or some type of intracranial bleed as a result of trauma? You know, what's the underlying cause there? So good comprehensive nervous assessments are essential when doing your trauma assessments. Moving on here, looking at the nervous system itself, a great little diagram here. Take some time and Google these images. There's a lot of good information that you can learn from looking over these pictures, and again with my Brady Lab, that's going to give you a lot of interactive study material. Review of the anatomy. Cranium represents the entire skull structure itself. We've got the facial bones themselves, 14 different ones. Mandible is the jawbone. Maxilla is the upper part of the jaw. We've got our nasal bones, the zygomatic arches, which represent our cheeks, and then the orbits around our eyes. And we've got a couple pictures of those coming up in a little bit. When looking at the spinal cord and brain both are surrounded by what's called cerebral spinal fluid, CSF. And what that does is it essentially keeps everything cushioned and suspends those things so that they're not rubbing up and creating friction against either the inside of the skull or against the spinal column. One thing I want you to note on this image here is you see kind of these lines in here, right? Think about when you were born, or when any baby is born, and the misshaped head that is normally indicative of a vaginal delivery. In those circumstances, right, we have soft spots. We have cartilage that hasn't formed yet, or hasn't hardened rather, and as a result, it allows these plates within our head to kind of shift and move around, and babies typically come out looking almost like cone heads to an extent. Think of these as like tectonic plates within the earth. The only difference is now they're fused, right? As the child gets older, and especially into adulthood, these things are all now fused. However, anywhere that there's a fusion point, it does create the potential for a weak spot. So what we end up seeing are fractures sometimes that follow along these lines. Generally speaking, it requires quite a bit of impact, quite a bit of force to cause a skull fracture, but if we do see them, there's the potential for it to break along those lines there. Knowing the number of vertebrae is going to be important. One, that's going to be an exam question, but two, we want to be able to determine approximately the site of a spinal cord injury because that will give us a lot of information as to what's going to be involved. So for instance, you may have heard the saying in the past, C3, 4, and 5 keep the diaphragm alive. Well, C represents cervical, so cervical vertebrae 3, cervical vertebrae 4, and cervical vertebrae 5. What ends up happening there is that's where the primary nerves branch off that control our respiratory function. So if we do have a blockage of communication or a fracture up at the C3, 4, and 5 region there, then it's going to affect our respiratory drive. And those patients are probably going to have to be ventilated. So again, just generally being able to count down and kind of figure out where everything is going to be important. One way that I've always remembered it is you've got 7 and 12. All right, lumbar is 5, which is the difference between 7 and 12. So 7, 12, 5, 5, and then 4 is the end. The coccyx is our tailbone, and these are actually all fused together here. So it's one large area of bone, but it does technically represent 4 different vertebrae itself. So you'll see here the coccyx all fused together here, whereas our cervical, thoracic, and lumbar vertebrae all work independently of each other. There's actually small discs that sit in between of each one of those vertebrae and allows them to move, and it kind of cushions them back and forth. So cervical, thoracic, and lumbar are all movable parts of the spine. The sacrum and coccyx are fixed, and essentially if you were to try to bend over and touch your toes, the bend in your back occurs right along in this area here. So one thing about scalp injuries is they bleed and bleed and bleed and bleed some more. However, reach up right now and touch your head. There's very, very little tissue between the surface of your skin and the skull itself, which tells you that the blood vessels there are going to be very, very small. There's plenty of them, but they all are small blood vessels. So what ends up happening is if we have a basic scalp laceration, it tends to bleed quite a bit. However, it's usually not going to be anything that's a life threat to us. Now, skull injuries, or scalp injuries rather, are really easily controlled by direct pressure, and that's all you should have to do to them. With skull injuries themselves, we do have two different types, are open and closed. I'll be honest with you, neither one of them is good, obviously, but at the end of the day, I'd rather have an open head injury than a closed head injury. And I know that sounds kind of weird, but when pressure builds up inside the skull of a closed head injury, it's very, very difficult to treat that and relieve it, and it's that increased pressure that ends up killing most patients. The open head injuries certainly opens us up to the potential for infection, opens up the potential for brain matter itself to be injured as a result of a penetrating trauma, but we're not going to build up that pressure. So I don't know that one is truly better than the other, but that's just kind of my mindset. So here's a great example of an open skull fracture here, right? You'll see that you've got a little bit of tissue along in here representing the scalp, and then beyond that, you're actually looking at brain matter down in here. This is obviously, it's a bad injury. What in the world could have caused some type of injury like this that actually opened up to the brain matter? And my guess would be, because I don't see any significant trauma or fractures anywhere else around here, that this is going to be a penetrating trauma, potentially some type of stab wound, or maybe a bullet wound even for that matter. So with the brain, direct and indirect injuries. With a direct injury, brain itself obviously is directly impacted by whatever the mechanism is. So the knife, the bullet, or whatever else it may be. Whereas with indirect injuries, it's literally just the energy that's transferred through the skull. That energy gets into the brain matter and causes some type of trauma there. So talking first about concussions. We hear a lot about concussions with professional sports, even pediatric sports for that matter. With concussions, it is not a physical trauma to the brain. A concussion is simply a chemical disruption in the brain. So we know that we have lots of activities that go on within the brain cells themselves to allow us to function. When we become concussed, there's a chemical disruption there that causes those brain cells not to operate effectively. But there is no physical trauma. It's simply a chemical disruption. If we have a contusion, right, now we actually have bruising of the brain. That's physical trauma. And they've got the words coup and contre coup listed in there. Coup and contre coup represent the impact areas of the brain in the event that it gets jostled around. So again, consider yourself, think of yourself in a car moving forward 55 miles an hour. You hit a brick wall, this car comes to a sudden stop. Seatbelt captures you, your body comes to a sudden stop. Your brain, meantime, is suspended in that cerebral spinal fluid in the skull. Your brain continues to move forward, albeit not more than probably a couple centimeters, and it impacts the front of your skull, front of the cranium, right? That is your coup injury. That's impact number one. Then your head snaps back and flings your brain to the back side of the cranium, and it now hits the back of your skull. That's your contre coup, or impact number two injury. Reason we need to be aware of those is because different parts of the brain form different purposes, and depending on where the injuries are in the brain is going to relate to the types of neurologic deficits that the patient presents with. So here's your blunt force again, right? This would be your coup injury, and then as the brain rockets back to the opposite side, that would be your contra coup injury. So we do have what's called a TBI, traumatic brain injury. You'll actually see patients that tell you that they have a history of TBI, and that TBI could be mild or severe. The patient could have permanent neurologic deficits as a result. And just like with a stroke patient, if we know we have a patient that's had a stroke in the past, first thing we want to ask is, do you have any long-term effects or deficits we need to be aware of? And that way we know that if they do, if that weakness on their right arm is normal and they've had that as a result of their previous stroke, that may not be indicative of a new one. Same thing here with the TBI. Is this a deficit you've always had? Have you always had vision disturbances? Have you ever always had anger issues as a result of it, right? It can affect our personalities. It can affect our physical function. It can affect our cognitive function. So try to get a good history of long-term effects from previous injuries if they exist. Looking at the different types of hematomas. If you remember, hematoma is a medical term for swelling. And the subdural, epidural, and intracerebral terms represent where in the brain the swelling is actually occurring. There are several different layers of tissue that surround the brain itself and essentially pad or protect between the underside of the skull. So those will give you an indication as to where it might be. Looking at this here, with a subdural bleed, we've got this dura mater. Again, 3 layers up here. The dura layer is one of them, and you actually have a bleed that sits beneath this dura layer. So this protective membrane, you can kind of see that the real thin area right along there is your dura mater. If the bleed is beneath it, or we would refer to it as subdural, whereas over here you can see that the bleed is above that dura mater, but it's beneath the level of the cranium, the skull bone, so we would call that an epidural. And then anything within the bleed or within the brain itself would be intracerebral. The only way to really know that these exist is through a CT scan. That CT scan should be pretty quick to catch any bleeds. If you ever have time in clinical to see a CT, take a look at these. And lots of times areas of either a faint or even a dense white represent some type of fluid, which is usually going to be brain or blood in the brain itself. With our patient care, common sense, right? Scene safety BSI, monitor ABCs, blah, blah, blah. Here's the big thing though. With head injuries, do we need to immobilize our patient? And it's a good question, because we know that we don't immobilize everybody now. We need to have a reason to immobilize. And recent studies have found that by laying patients on a hard board, especially our elderly demographic, that it can actually cause some additional injuries. Beyond discomfort, it can make the injury worse in some circumstances. If the patient is complaining of head or neck pain, they have some type of neurologic deficit, absolutely 100%, they need a C-collar on. And if it's appropriate, then go ahead and lay them on a backboard. But it's also equally acceptable to strictly lay them on your cot, and that be the immobilization device, right? If they're laying prone, or supine rather, on your stretcher, and they're holding still, that's immobilization. They don't need to be on that hard backboard. We use the hard backboards now more for patient movement than we do for mobilization purposes. And now here's the critical thinking question. Picture your patient sitting in the semi-Fowler's position on your stretcher. They have a C-collar on. Is that acceptable for mobilization if they have neurologic deficits? Think back a few slides here, and let me bounce back and I'll illustrate this. So if they're in the semi-Fowler's position, this is your tailbone, right? So this is down in the patient's butt. This is where the bend of the back itself is. So from here up is in the upper section of the torso or upper section of the cot at a 45-degree angle. And then this area down here is actually sitting on the cot, right? And that would be on the lower portion. It is acceptable because when we need to immobilize, our spinal cord itself comes down, it exits out of the back of the skull, comes down through the spinal column, and the cord itself terminates right about here. So if I were to break my back at, let's say, L4, L5, I could break it. I could sever that spine completely and not have neurologic deficits. And the reason is because the spinal cord, which controls all the nerve function, terminates right around the L3 area, right about here. So since the bend in the back is going to be down here to have a patient in the semi-Fowler's position, there is no impact to the spinal cord. As a result, we can comfortably immobilize our patient on the cot without having to have them on a hard backboard. Of course, there's exceptions to that, and if you need to put them on the backboard, you certainly can. Just don't feel that you're obligated to do so with every single patient. Something else to point out. So looking at this from a chronological perspective, right? Scene safety, take your standard precautions, your BSI things. Consider possibility of spine injury, which means that as we're approaching our patient in the primary assessment, if there's mechanism to support the need for immobilization, we should take C-spine right away. And notice how that falls above airway. So again, scene safety BSI, we identify mechanisms that suggest the need or could suggest the need of a spinal immobilization, and we do it right away. We hold C-spine. At that point, while I hold C-spine, I can then equally assess the airway. I can assess the breathing pattern and efficiency, and then I can go on from there. Notice the controlled bleeding is at the end. Now, we're beginning to see a little bit of a shift in civilian treatment for trauma. In the past, it's always been ABC, ABC, ABC. If you don't have an airway, you don't have a patient, so who cares about anything else? But I'm here to tell you that we've found through good scientific studies that we lose more patients from bleeding out than we do from airway issues. So what they're beginning to accept is the fact that if you approach your patient and they have a life-threatening bleed, and the key terms there are life-threatening. If they have a life-threatening bleed, it is okay to go ahead and address that wound first, and then go back and check your ABCs. Now let's again do a little bit of critical thinking. If they are actively bleeding, if you see spurting blood coming out of a wound, you know they have a pulse, right? I don't need to check for a pulse to know that they have one if they're bleeding. If they didn't have a pulse, the heart's not functioning, they wouldn't be bleeding now, would they? So it's easy for me to say, okay, I approach this patient, they have this arterial spurting wound. I know they have a pulse. I need to stop this because even if I resecure their airway and give them all the oxygen in the world, if they don't have blood to transport the oxygen, what good is it? I can put oxygen back in my patient later on. I don't have the ability to put blood back in them. So if we identify a life-threatening bleed, stop, go ahead, apply some direct pressure. Now, you may not want to take the time to make this beautiful dressing and wrap it with a bandage and stuff like that, but you can apply pressure with a hand, drop your knee into a wound, whatever, to begin to stop the bleed while you simultaneously still assess airway and breathing necessities. Now, here's what I don't want you to be blinded by. Bleeding in itself, especially profound bleeding, is very distracting and it causes tunnel vision. If I had a 2-inch laceration on my scalp and it's bleeding and bleeding and bleeding, that's not a life threat. So do you understand the differences between life-threatening and non-life-threatening bleeds? And that's what we have to consider. I would not delay airway and breathing assessment and treatment to treat a scalp wound. I wouldn't. I would delay it if they had an arterial bleed from the femoral artery in their thigh, or even from the brachial artery in their arm. So we need to be able to really figure out what exactly is life-threatening and what is not. And then the last thing here, keep the patient at rest, only makes sense, right? If they're injured, we don't want them moving around a lot. Talking to our patients is really important. We know that from the stroke chapters and stuff that even though a patient may be semi-conscious or unconscious, a lot of times they can still hear us and they're still aware of what's going on around them. Especially in the instance of a trauma, providing that emotional support, reassuring them that you're going to take great care of them, and especially telling them what you're going to do before you do it. Very, very important. If you have an unconscious patient and then all of a sudden you start cutting clothes off, again, they may not show any level of embarrassment because they're unconscious, but they still know they're still uncomfortable. Speak out loud. You know, hey John, my name is Scott. I'm a paramedic. Just so you know, you've been involved in a car accident. We've got you in the back of the ambulance. I'm going to be cutting your clothes off so that we can look for any injuries that you might have. And I know it kind of seems funny talking to an unconscious patient, but trust me, there's some very, very good benefit to it. Monitor vital signs every 5 minutes. That's a guideline. That whole 5 minutes if they're critical thing, 15 minutes if they're not. Again, it's a guideline. In my class, I want you guys to think for yourselves. I want you to know what you're doing and why you're doing it. So if I have a truly critical patient that is unconscious, they're in decompensated shock, do I want you to wait every 5 minutes? Should you be monitoring that pulse constantly? Can you set the blood pressure to every 2 or 3 minutes? Conversely, if you have a patient who you need to, I don't know, you're trying to apply a splint to the arm and dress a wound and stuff like that, and it takes you longer than 5 minutes to get a blood pressure, is that okay also? Sure. These are guidelines. Look at your patient, determine what they need, and treat them appropriately. So we talk about intracranial pressure here. It's called ICP is what you're going to hear it abbreviated as. And that's the amount of pressure that's inside the brain at any given time. And it's normal for there to be small amounts of pressure, just like blood pressure throughout the rest of the body. However, in the event that we have an injury to the brain, we can start to see an increase in ICP, an increase in intracranial pressure. And that increase in pressure applies downward pressure on the brain itself. It affects us neurologically, and as time goes on and that pressure continues to build and build and build, we'll start to see a shift where one hemisphere of the brain starts to push over toward the opposite side of the skull, and at the very tail end, they'll begin to herniate through herniate the brainstem, where the only opening in the skull is through that hole in the bottom, that foramen magnum, and as the pressure increases, it begins to push the brain out that little tiny hole. That's called herniation. When we see that, think about the brainstem being pushed against the side of the skull, side of the cranial wall there. What does the brainstem control? Well, think back, it's got the medulla oblongata, so therefore we're probably going to see respiratory impairment. And lo and behold, when we begin to herniate, we start to see what's called Cheyne-Stokes respirations. It's a very irregular pattern of respirations where they're shallow, they're deep, they're fast, they're slow, and it's literally just all over the place. There is absolutely no consistency to the respiratory pattern or effort there. And that's going to be one of the biggest indications that, they're herniating. Once they begin to herniate, there's very little chance of survival for this patient. So that tells us that with any type of injury, especially here with head injuries, the sooner we get them to the hospital, specifically the sooner we get them to a neurotrauma center, then they can begin to relieve some of that pressure. So how do we identify the presence of a head injury that presents with intracranial pressure? Well, here's the first thing, a rising blood pressure and a slowing heart rate. So with the rising blood pressure, the brain itself says, hey, I'm not getting perfused adequately, so what I need you to do is pump more blood up. And it causes an increase in blood flow to the brain. And what that does is that continues to increase the pressure, and we'll actually start to see a widening pulse pressure. If you remember back to the thoracic chapter, we talked about a narrowing pulse pressure for pericardial tamponade. Now we're talking about a widening pressure with these head injuries, where the systolic pressure starts to rise and rise and rise. Meanwhile, the diastolic pressure rises much slower. These patients with ICP, we're going to start to see their pressures creeping up to 160, 180, 200, 220, 240 systolic. It is not uncommon for you to have an ICP patient that has a blood pressure of maybe 220 over 150, 160, something like that. In addition to that, the slowing heart rate. What causes our heart rate to increase during trauma, or to increase as part of our sympathetic response, is neurologic communication from the brain that goes down to the adrenal cortex on the kidney. The adrenal cortex is then stimulated to release epinephrine and other catecholamines, which go directly to the heart, and they increase the heart rate. That's what happens during a sympathetic response. In this case, though, since we have a head injury with intracranial pressure, a lot of times the ability for us to send out those communications is limited or eliminated altogether. So as a result, even though we would like to see an increased heart rate to help compensate, we don't see it because the heart does not have that outside influence from the brain telling it to beat faster. If the heart doesn't have an outside influence, it beats at that inherent rate of the SA node, which is anywhere between 60 and 100. Without any stimulation, you should see a heart rate probably right around the 60 range. 60 to 70 is probably going to be what's considered to be normal there. Altered mental status, I think, speaks for itself, right? If we can be altered from a simple concussion, we can certainly be altered from a significant traumatic brain injury. And then dilated pupils or sluggish pupil reaction, that's going to be a later sign. The sluggish pupils is something we could see right away, even with a concussion. As we evaluate pupils, they may respond to us, but maybe they're kind of slow to respond. When they become dilated, you'll hear the term blown pupil. And depending on which side of the brain the injury is on, a single pupil will be affected first. Assuming that I've got an injury just strictly on the right side of the brain, then I'm going to see a blown pupil. Now, it could be right or left. I know a lot of times people think that if the injury is on the right, we see everything on the left, and that's not necessarily true. The optic nerves do crisscross. So the optic nerves originate in the back of the skull, back of the brain, and they move their way forward to the eyeballs themselves. And because there's a crisscross there, if the injury is toward the front or back of the brain, it may affect pupils on the same or opposite side. So just, not that it really makes a difference, but don't assume that if the pupil is blown on the left, the injury is on the right. But nonetheless, if we do have a single blown pupil, that means that we have some type of injury where the other pupil is still responsive. As time goes on, and we begin to see that shift in pressure, and the hemispheres of the brain shift from one side to the next, or especially if we begin to herniate. Well, now we have pressure on both optic nerves. Neither one of them are working efficiently. As a result, the default for anything in our body, and when it's not stimulated to do something, is to relax. And for us, pupils are relaxed in the dilated state. So we see bilateral dilated pupils that are fixed, non-responding. That tells us, okay, this patient's, they're at the tail end. They're probably going to start herniating soon. We should probably be looking for those Cheyne-Stokes respirations and preparing for the worst. So I'd look for those pupils right away, check that blood pressure right away. And again, if you see this hypertension with a normal to even bradycardic heart rhythm, in addition to that, they've got dilated or sluggish pupils, that should be screaming at you intracranial pressure, head injury, etc. These patients need a level 1 trauma center, and they need a level 1 trauma center that specializes in neurologic injuries. So there's the Cheyne-Stokes I've been talking about there. With the central neurogenic hyperventilation, that's the result of the Cheyne-Stokes, mostly because, again, the brainstem is no longer functioning like it should. You're going to hear, and you'll see in some protocol books, that in the event that a patient is showing signs of a herniating brainstem, that you are supposed to hyperventilate them. And here's the thought process behind that. And we've talked about this before, right? There's a hazard to hyperventilating our patient when they don't need it. And the reason is, if we hyperventilate, we breathe off too much carbon dioxide. In that case, the patient becomes alkalotic, and in an alkalotic state, we start to see vasoconstriction. If we vasoconstrict, we reduce perfusion to the brain, and that's where we start to see patients with altered mental status. Think about your anxiety attacks, right? Patient's breathing too fast, breathes off too much CO2, takes them to an alkalotic state, they pass out, right? That's a typical function. In this case here, we want that to happen. By hyperventilating our patient and causing that alkalosis and vasoconstriction, we're reducing blood flow to the brain. Now, yes, reduced blood flow to the brain is bad, but when the pressure is already so high that it's beginning to herniate, the thought process is, well, hey, if we can slow that herniation down, maybe it gives them a couple extra minutes to get to the hospital and try to relieve that pressure. Let's be honest here. If a patient is injured to the point that they're herniating their brainstem, if they are able to survive, they're going to have long-term deficits no matter what. So at this point, we're not trying to eliminate injury. We're just trying to do whatever is possible to try to buy them a couple minutes of time. Looking at impaled objects, you could have a stab wound, you could have a knife sticking out of your skull and still be walking around functioning 100% normal. Depends on the parts of the brain that are injured. And we know that there's a lot of parts of our brain that we could have removed even, and maybe not impact our everyday life substantially. Whereas there's other parts of our brain that if it's injured just a little bit, it could be catastrophic. If we do have an impalement, we never want to remove it. Nothing different about the skull than the rest of the body. If you have to cut it down, do so. Obviously, when you go into your fire classes and you talk about how to cut objects and remove impalements, or I should say, take a piece of material that is impaled, cut it down so you can transport it, you'll talk about being careful with vibrations and heat transfers and stuff like that. And obviously, if it's in the brain, we want to be especially careful. So if we are looking at facial injuries here, face and jaw, primary concern, airway, how do we control it? There was an instance in Woodstock years back. I was not on the call. A couple of the guys I work with were, and a gentleman attempted to commit suicide by placing a shotgun underneath his chin. Pulled the trigger. The angle of the gun blew the face off, but did not actually go back into the cranium, didn't kill him. He was certainly unconscious when they got to him. They found him without any recognizable facial structures, and they thought that he was deceased. So they were going to put the monitor on him just to print the strip to confirm when he sat up and started moaning. So now they were posed with this patient with severe facial structure injuries that needed to be cared for, right? This patient's alive. What do we need to do to save him? And it took quite a bit of work between them and the flight crew. Eventually, they were able to get this patient intubated. What they did is they just looked for the air bubbles rising up through the bloody mess of a face that was left, and they started kind of poking around until they found what they thought to be the trachea, and fortunately it was. They were able to get that tube placed. Airway management with facial injuries is very, very tough. I treated a patient a few months ago that was thrown from his motorcycle wearing a helmet, but it was an open face helmet, and landed square on his face and really just messed up every facial structure there. So when I went to try to intubate the patient, it was really tough because the jaw, while the jaw was broken and easier to manipulate, all of the anatomy was kind of pushed around and shifted. Plus the amount of blood that was in there made it difficult to see. These are just tough to work with. If you can place a king tube, fine, but think about it. If the face is blown off partially, are you going to be able to form a good airtight seal between the upper and lower balloons in order to push air down the trachea? If both of those balloons aren't sealing off an airway structure so that the air is trapped between them, then the air is not going to be delivered down the trachea. So a king tube may not work in this case. For non-traumatic brain injuries, this is going to be your strokes, aneurysms, that type of stuff. You covered this back in the medical chapter, so there's not really a whole lot that we need to talk about in this case. Anytime we have an altered mental status, we should be calculating a Glasgow Coma score. Again, something we've talked about in the past. If you don't have this down yet, keep studying it. You need to be able to calculate it, and you need to be able to calculate on the fly. This is something that the nurses will ask for when you call in your radio report. They want to know GCS. It's a numerical way to represent the patient's mental status, and it's very easy for us to represent increases or decreases in their status. Going from 13 to 14 is a clear improvement, whereas going from 13 to 12 is clearly getting worse, and it's a great way to represent that without having any subjective components incorporated there. So I'm not going to go through these in detail. You've got that information. Make sure you cover it. With wounds to the neck, here's a tough thing, right? We can't put arteries around the neck. Hopefully you understand why. If you can't picture why, a tourniquet would be good. I may have just mixed up my words. We cannot put a tourniquet around the neck. Obviously, that's going to include the airway. It's going to reduce blood flow to the brain. Doesn't really accomplish a whole lot. If we do have arterial or venous wounds to the neck, it's simply a matter of applying direct pressure over those areas. The other thing we may need to do is put occlusive dressings around the neck. If the trachea is involved, or if air gets into the areas around the major vessels within the neck, that air can actually build up pressure. It can occlude blood flow to and from the heart, or to and from the brain rather, and it can also cause issues with the trachea. So direct pressure, and if appropriate, you may need to put an occlusive dressing over the neck also. We're not going to worry about this right now. Patient care is the same as always. Injuries to the spine. Okay. So we're going to assume injuries to the spine based on the mechanism of injury. If they were thrown from a motorcycle, they fell off a second floor building, etc., it's reasonable to say, okay, there's a good chance that they have a spinal cord injury here. First of all, take C-spine precautions, maintain that mobile stabilization or that manual stabilization, and then from there immobilize whatever, using whatever tools are appropriate. So looking at this here, right? Great examples of mechanism that can cause these types of injuries. You know, have you ever thought about immobilizing somebody in a pool? Lifeguards are trained to do this. Our backboards are flotation devices. You can bring the patient up, you can keep them floating at the top of the pool in a neutral alignment, and you can actually roll them right onto the backboard and use that as a flotation device and then pull them out of the pool that way. When we're looking for it, the mechanism is going to be the biggest thing. You know, with this case here, if this pool is 15 feet deep and the patient has an altered mental status, is it trauma related? I doubt it, right? That would take one hell of a dive to get to the bottom of a 15-foot pool and hit your head. If I have an altered mental status patient in a pool, I'm thinking of something else completely unrelated to trauma. However, did they hit their head on the diving board? That might be something to consider. So overall, looking at the mechanism is going to be really important. If this is a 3-foot pool, yeah, I'm thinking that a dive injury could definitely be the underlying cause. We do have our level 1 transport criteria. It provides that for you in your protocol book. In addition to that, we've got these other criteria. A lot of these were covered back in the assessment chapters, but in this case here, a fall for adults of 20 feet or greater is a level 1 criteria, and then for children, a fall of greater than 2 to 3 times their height is a level 1 criteria. Beyond that, we're looking at some other things here too. So mechanisms for spinal cord injury. You know, here it says roughly 3 feet or more than 5 stairs for a basic fall. And it really depends on how you land, right? If you fall forward and you're able to catch yourself with your hands, a fall from standing is no big deal. But imagine being an elderly patient that falls backwards and lands square on their butt. As a result, you might have those compression fractures from the axial loading. So I told you that there were those discs between each of the vertebrae. Imagine now if your spinal column was kind of stretched out, had these discs in between each vertebrae to space them out, and now all of a sudden you compress that and you push down on it. We can cause some fractures there. All of our peripheral nerves exit out the sides of each of those vertebrae there. So as I compress vertebrae in my back, I'm also going to be compressing the peripheral nerves that exit through those spaces. Additional high-risk mechanisms, motorized recreational vehicles. So we have ATVs, motorcycles we see quite a bit. I've had motocross guys that have been doing jumps and stuff like that that have resulted in spinal cord injuries. So again, just consider the mechanism and the potential for those injuries to be there. Remember that a spinal cord injury may not always present right away. Neurogenic shock is not going to set in immediately. That's all stuff that takes time. So we need to use mechanism to determine if there's the potential for that to occur down the line. We're not going to worry about dermatomes. That's not something that you're going to be tested on, so we'll skip over that. What we should be looking for is basic numbness, tingling, paralysis, any of that stuff that would suggest that there's some lack of neurologic communication back to the brain. You know, obviously, if I can't feel something in my left hand, then I've got some type of neurologic interruption there. Same thing with numbness and tingling. If we're unable to move and we have complete paralysis, another big indication. Usually with paralysis, it's going to be bilateral on both sides if it's a cord injury. If it's a peripheral nerve injury, it'll be unilateral. So if my left arm is paralyzed, but my right arm is not, that tells me that the injury is probably not to the spinal cord, but it's to the peripheral nerves somewhere off on the left side of my body that control my left arm. So I'm going to start looking for injuries there. Priapism is something in males that we can look for. Again, I told you that anything in a anytime something lacks outside stimulation from the brain, the inherent response is just to relax. With blood vessels, the inherent response for relaxing is to dilate. That is their relaxed state. So anytime that we have lack of neurologic communication below a certain point in the body, we're going to have widespread vasodilation. That's what causes our patients to go into neurogenic shock. And with the priapism then, all of the blood vessels in the penis tend to dilate. It allows for excess blood flow to the penis in that case, and it gives a partial erection. It's not going to be an erection that you would imagine if somebody was aroused or engaged in sexual activity, and it's not even something that you may notice if you fail to expose your patient. Again, a great reason that we need to be stripping our patients down. For me personally, trauma patients, they're stripped butt naked in the back of my ambulance. So I want to be able to see everything, which includes things like priapism on males, and I want to be able to observe any type of vaginal bleeding from females. You can do more and see more with your eyes than you can with your hands in any given period of time. Additionally, we look at the potential for incontinence. So you've got sphincters that essentially hold the urine inside the bladder and hold your bowel content inside your colon. If in the event there's a lack of neurologic communication to those sphincters, again, they relax by default, which means that they dilate, and we'll see incontinence. The patient may urinate themselves or they may defecate themselves. A lot of times, if there's any type of bowel content in the colon, one of the ways that we can confirm death is if they have taken what we use as a slang term, we call it the death dump. But essentially, they defecate themselves, and that's an indication that, okay, all neural communication has been lost, and there's a good chance that they're deceased at this point. Now we got neurogenic shock. As we get into neurogenic shock, there's some things coming up here. Here's the thing to consider. With neurogenic shock, there is some type of spinal cord injury. Let's say that the injury is to T12, right? So it's the very last thoracic vertebrae somewhere in the middle of your back. That's where the injury is. There's going to be paralysis below the points of the injury. And because that paralysis is there, because there's no neural communication, that means that every blood vessel in the legs and in the pelvis are going to dilate by default. So we're going to have a profound amount of our blood volume down in those lower extremities. With neurogenic shock, we don't lose blood, but our container, the blood vessels that house all of our blood, gets bigger. So we have the same volume of blood, but we now have a much larger container. As a result, we can't maintain the systemic vascular resistance. We can't maintain the blood pressure as a whole. So we start to see our patient become hypotensive. Now, in most cases with shock, if we see hypotensive, we would expect to see tachycardia to go along with it, right? That's our compensatory response. However, in this case here again, since we have lost communication from the brain, there's a good chance that the adrenal glands cannot be stimulated, and therefore those catecholamines are not released. If those catecholamines aren't released, the heart doesn't increase its rate to compensate. So we're going to, again, just like when we talked about our increase in our cranial pressure, we're going to see the heart remain in a normal rate or range, probably at or around 60, give or take a few. Looking at spinal immobilization then, if it's indicated, do it. If it's not, don't. Consider your patient's position and comfort when you do. You could use a KED board, right? Even though a patient may be laying on the ground, you could still use a KED board to immobilize them. The great thing about the KED board is it doesn't put them on a long, rigid, hard board that they have to lay on, but it does do a good job of immobilizing the upper half of the body. So everywhere where that spinal cord is, where we need to protect any further damage, that's going to be covered by the KED board. That's a great tool that we don't use nearly often enough. So spinal motion restriction, C-spine, that's just you taking your hands manually holding the neck. That's a skill that we'll practice more in class with our breakouts. You'll do that on nearly every single trauma patient you come across. There's a bunch of other devices. A lot of these, again, we'll play with in class. Nothing worth talking about in a lecture or discussion. So a great example, this gentleman in the back here, his job is to hold manual stabilization while this person comes in, properly fits, and applies that C-collar. The purpose of a C-collar, it does not prevent movement. That's not its intent, and that's not its function. The purpose of a C-collar is as a reminder to the patient and to us that they should not be moving. Even if you properly apply a C-collar, if the patient wants to move their head left and right, they can. It's more difficult, but they can. So again, it's just a reminder, hey, I need to hold still, I need to keep my head looking forward here, and it's a way to help the patient keep their head in neutral alignment so there's no further damage. Something I want you to think about, 90% of spinal cord injuries occur at the time of the accident. So in this case here, for a car accident, right, if this woman was to have a spinal cord injury, there's a 90% chance that it would have actually happened at the time of the impact, and only a 10% chance that it's going to happen later on or as a result of EMS provider intervention. So not that 10% is something we shouldn't be concerned about, but just know it's likely going to happen already. We'll talk about sizing and application of C-collars in class. No big deal. We want to be sure that we're using the appropriate size collar. We'll also talk in class about immobilizing children in their car seats if it's appropriate, and other ways that we can take care of kids that otherwise won't be supported with our adult equipment. We talked early on, chapter 3, I believe it was, patient movement, about the difference between emergency moves, urgent moves, and stuff like that. If the patient is presenting with head, neck, or back pain, they have neurologic deficits, we should take our time, properly immobilize them, make sure we do everything just slow and methodical. However, if that same patient has complaints of head, neck, or back pain, they have neurologic deficits, but they're in a car and they're showing signs of decompensated shock, I need to get them out of the car and get them to the hospital, right? Immobilizing them in the car isn't going to save their lives. Getting them to the hospital to reverse the shock is. So in that case, this is going to be a high priority patient. I would certainly not use a KED board to remove this patient. I would probably use manual stabilization of the head and the neck, and I would just carefully remove them as quickly as I can. Once I get them out, I can take more time to mobilize and restrict their movement further if need be. So we'll talk about the different tools available. I'm not going to, this is the KED device here. You will practice that in class. Nothing I'm going to talk about in the discussion here. These standing takedowns are something that used to be something we would do all the time. If a patient was involved in a car accident and they were out walking around when we got there, we would say, oh my goodness, you've been involved in a car accident. Mechanism of injury says you might have a spinal cord injury. Stop what you're doing. And we would literally stop them right where they stood. And then we would put a backboard up against them. We would hold on to them. We'd put a collar onto them. And then we would slowly lower this patient down to the ground. Well, again, further studies have shown that this really isn't necessary or appropriate. If your patient is ambulatory, meaning that they're up and walking around when you get there, and they're conscious and they're talking, and you say, hey guy, do you have any pain? Does anything hurt? And he says no. All right, does your head, neck, or back hurt? No. Okay, fine. Don't immobilize him. Even if he is walking around and he says, yeah, I was just in this accident, my neck kind of hurts a little bit. Obviously, if he's up walking around, he doesn't have a spinal cord injury right now, right? In this case, we could still be cautious, though. We'd say, okay, walk over to our cot. I want you to carefully sit down on the cot, and we're going to rotate you around, and I just want you to hold real still. I'd probably still put a C-collar on them, right? That's not going to hurt anything, but I would certainly just put them directly on the cot and immobilize that way without the use of a backboard. When it comes to helmets, again, a skill that we'll practice in class. If we can leave the helmet on, we want to do so. But if the helmet itself is damaged and does not keep the patient immobilized, or if it's blocking the airway and we need to take care of airway maneuvers, then it may be appropriate to remove that helmet. This is a skill that we'll practice in class, and we'll talk more about when it is or is not appropriate to remove it. And that is really the end of it. So kind of a simple chapter here, a lot of common sense. Big focuses for this chapter are going to be reviewing the intracranial pressure, signs and symptoms of a neurogenic shock, rather, how to assess for those, how to treat those, all sorts of stuff. The actual hands-on psychomotor skills are things that we'll do in breakout sessions in class. So I hope you guys enjoyed this. If you have any questions, let me know.